Our second night of FETP International Nights. It's a real pleasure to have you here. My name is Kip Baggett, and I'm the branch chief for the Workforce and Institute Development branch at CDC. And that is the branch that houses our support for the Field Epidemiology Training Program, as well as National Public Health Institute program. And we're very, very happy to have you here tonight. Before we get started, just a couple of housekeeping notes. As has already been mentioned by that voice that came from the ether, please silence your cell phones. We want to be respectful of all our presenters tonight. And in case of any emergency, please look around and identify the exits. I think we have exits on both sides of the room. And also note that tonight's event is being live streamed on TEFINET's YouTube channel. If you were unable to join us last night for the poster night, speakers and poster previews were also live streamed and can be watched on TEFINET's YouTube channel, so check those out. And if you did miss the poster session last night, you missed a lot. I want to give a real shout out to the poster presenters, their mentors, and their programs from last night. They were excellent. I really think some of the best poster presentations of any international night I've seen. So let's, congratulations to them again. And this was mentioned last night, but I'm going to say it again for those who weren't here. We received 189 abstracts for International Night. So there was a lot of interest, but we were only able to accept 22 posters and eight for oral presentations. So what you're seeing is really the cream of the crop, some really, really great presentations. And you may be aware that we accepted 8 oral presentations this year. 2 of those oral presentations were chosen to be presented during the daytime session of the EIS conference on Monday. And so congratulations to Dr. Nguyen of the UK FETP and Dr. Hamuchine from Zimbabwe, who presented during the daytime session. You won't hear their presentations tonight, but we do want to recognize their great work. So tonight we will feature 6 oral presentations that will bring a range of infectious and non-infectious disease investigations from COVID-19 to Salmonella, HIV, mental health, and others. And we're very excited about those presentations. As every year, I think you can expect excellence from our oral presenters tonight. We do have a couple of special speakers to kick us off, and I'm going to introduce one of those now. It is my pleasure to introduce Captain Simon Aguilore, who's the Acting Director for the Division of Global Health Protection here at the US CDC. And in his role, Captain Aguilore leads a team of experts based in the US as well as around the world who are doing great work strengthening health systems to enhance global health security. Dr. Aguilore is an epidemiologist and infectious disease physician with decades of experience in infectious disease work and public health program development and implementation. He began his career at CDC as an EIS officer in 2009 in the Division of Global HIV and TB, and has held many positions since then, including serving as the CDC country director in Namibia from 2014 to 2018, and in Zambia from 2018 to 22, where he played a key role in the rapid scale-up of HIV treatment services, helping both countries to achieve the UNAIDS 90-90-90 targets. Dr. Aguilore was also instrumental in the development of strengthening national public health institutes in both Namibia and Zambia, and has been a long-time strong supporter of field epidemiology training programs. So I'm going to now turn it over to Dr. Aguilore and have him deliver his remarks. Thank you.
Good evening, everyone. Thanks, Kip. and FETP for inviting me to be part of the 22nd FETP International Night. I am really excited. More than about 14, 15 years ago, I attended the first one, and it was quite an experience. But I see that things have gotten much better compared to 15 years ago. So I'm delighted this year's conference is back in person after being virtual for the last 2 years. And I want to talk briefly about FETP and how proud we are of FETP. As many of you know, over the last 43 years or so, FETP around the world have trained over 22,500 graduates across more than 90 countries in the 3 levels of FETP. And over 80% of the trainees continue to work in their home countries, including many in leadership roles. The 3-tiered FETP program, the Frontline, Intermediate, Advanced, allows Ministry of Health to strengthen surveillance and epidemiology capacity at all levels of public health systems, from local to regional to national levels. I have been fortunate to see firsthand the direct impact of FETP graduates and trainees in my current role within the Division of Global Health Protection, but also as a country director in Zambia and Namibia before then. So in Zambia, for example, the FETP training program residents were able to conduct one of the first seroprevalence studies that showed the burden of SARS-CoV-2 among healthcare workers and in the community. And they were also instrumental in doing one of the first studies to show real-world effectiveness of COVID-19 vaccine, providing critical data for policymakers in Zambia and regionally. John Simwanza, FETP resident, led investigation in December 2021 after learning of a COVID-19 outbreak in a Zambian prison shortly after Zambia found that Omicron variant was circulating. He found that vaccinated persons were less likely to get infected and less likely to have severe COVID-19 symptoms. These findings are important for Zambia because most vaccines studies were done internationally and not in Africa. And I can tell you that the Zambian government was so proud of these studies, and they embraced COVID-19 vaccination, and Zambia achieved WHO and Africa CDC targets for COVID-19 vaccinations, one of the few countries that did that in Africa. The past 3 years alone have brought stark memories of the threats that face us from COVID-19 pandemic, and right now, for the first time, Marburg in Equatorial Guinea and Tanzania. CDC continues to expand FETP with plan to support, start, or strengthen FETP in 29 countries. FETP are crucial to CDC mission of global health security, and CDC is committed to supporting these valuable programs. Today, more than ever, FETPs play a crucial role to prevent, detect, and respond to public health threats wherever they occur. As we continue to battle public health threats, it is important that we evaluate what works and what we can do better and where we can innovate. So right now, we're working on improving the frontline curriculum to incorporate One Health, because we know that many of the countries are asking for it. And we intend to do something similar with the intermediate curriculum in the coming months and pilot this in some countries. In fact, we're piloting the frontline right now, One Health curriculum in a few countries. In collaboration with Tufinet, the University of Val de Guatemala, CDC developed a new online FETP mentoring training as part of innovating and trying to find new ways to train our FETP mentors. This is being piloted over the next 4 months. So thank you for continuous effort in improving FETP to make it all it can be to save lives. We continue to battle other threats such as polio, measles, and many other diseases, communicable and non-communicable, as we also prepare for the next outbreak. Our work never stops. So thank you for your hard work to keep the world safe from diseases. And I wish you all a great time at this conference for the remaining day or two. And now I would like to introduce our Principal Deputy Director in the Center for Global Health, Dr. Kevin Kane. Dr. Kevin Kane became the Principal Director in 2020. He leads CDC effort to protect and improve health global globally through science, policy, partnership, and evidence-based public health actions. Before returning to Atlanta, he served as the CDC country director in Tanzania from 2017 to 2020. In 2011, he became the first TB director for CDC Kenya in Kisumu and later served as the director of Western CDC Kenya office. Dr. Kane began his career at CDC in 2004 as the Epidemic Intelligence Service Officer in the Division of TB Elimination in the International TB Branch, where he received the Scientific Award for Global Health Excellence. He is a well-renowned TB expert and has done so much on things like symptomatic screening for TB. So Dr. Kane earned his medical degree from the University of Pennsylvania School of Medicine in 2001, and he co-authored over 100 scientific articles. Please join me in welcoming Dr. Kevin Kane.
All right, good evening, everyone. Nice to see you. First, I want to thank you for joining and acknowledge that this is the 70th year for EIS conferences, and I believe the 22nd for the International Night. So congratulations on that. Those are good things for us to celebrate. I'd also like to start right up front by acknowledging TEFINET. TEFINET has been CDC's long-standing partner in implementing and executing FETP with excellence. And we really appreciate all they've done and all they've brought to the table, and are grateful for all that you do. I thought in these couple of minutes that I have, I would share with you some of the feedback I've heard from ministries about the FETP program. Earlier this month, I had the privilege of traveling to DRC. And when I went to DRC, I met with the high-level government officials. The director of the national lab was one of those officials. And when I met with him, he said, "The experts graduating from the FETP training are the pride of the country because they are out in front of outbreak response and disease control in DR Congo and across Africa." Then we met with the new Minister of Health. I think he had been the Minister of Health for about 2 weeks, but before that, he was the special advisor to the president and had helped push through the bill that would make the National Public Health Institute and universal health care something that would be in DRC. When we met with him, he really emphasized the importance of workforce development and specifically called out FETP as well as the Public Health Emergency Management Fellowship as two things that were very important to him. Just last week, we hosted a high-level delegation from the Thai Ministry of Public Health. Usually at these delegations, I would highlight the importance of FETP, but what I found was that 4 of the high-level leaders that had came from the Thai Ministry of Public Health were FETP graduates themselves. And then the Director General told us, FETP was the best investment of the Thai government in this area in the past 40 years. These are not stories that I've picked out over a long, extended period of time. These are stories just from the past month, just from April. We hear these things all of the time, and that makes me wonder, what is it that makes FETP so special that I hear from government officials wherever we go without me raising anything? Is it the multi-level training that Simon alluded to earlier? Is it the fact that you've had over 20,000 graduates, and from what I recall, about 98% were involved in the COVID-19 response in some way or another? Is it because of the access that they have and the commitment that they've demonstrated? When I was in DRC, I also met with 7 current trainees of FETP and FEM, and they told me about their experience working in North and South Kivu in the most difficult circumstances during the Ebola response. And they made such an impact. And I thought, how often do you have a chance to sit and listen to heroes who are out there doing the work that absolutely needs to be done and wouldn't be done without them? So to me, the answer is yes, those things are part of the story, but I believe the answer is much more than that. And actually, it's kind of nice standing on this stage looking out at all of you because I have a perspective that you probably don't from where you're sitting. And that perspective is that I think I can see the answer right in front of me. I see a lot of people who are FETP trainees or former FETP trainees, people who have graduated from the program. I see people who are friends of FETP who have really done a lot to support the program, to make it what it is. And when I think of why it is that FETP is so special, I think that you're the answer to that question. So yes, it is the many things that we talked about, but really, it's all of you. I think we have a group of courageous, committed people who have dedicated themselves to solving the world's most challenging problems. You know, I'm struck by the fact that we sit here and say, what is our goal? Our goal is to identify epidemic threats at their source as quickly as possible before they spread somewhere else. That's hard. I mean, there are a lot of countries out there. This is not an easy thing to do, and the only solution that will work is a local solution. And that's why FETP is so important. Skilled, trained, committed disease detectives who are working in their home area, bringing the best we can to those areas. So where do we go from here? I'll offer one piece of advice, which you can take or leave, and then I'll also offer a commitment. My most important advice to you, and this is especially to the FETP folks, but actually it applies, I think, to everyone in this room, and I guess those who are joining us on the YouTube stream, which I did not know about. My most important advice to you is to be the courageous leaders that we need at this time in this complicated world. I don't have to tell all of you that the world has become a crazy and complicated place. Leadership is hard. If there's one thing I know that. But what I encourage you to do is to have the courage to do the really hard things, because it's those things that are going to make a difference. So ask yourself, what is the area, the disease thing, the goal that might feel a little bit out of reach, but maybe it would have a huge impact? Ask yourself, what are the things that you would do if you weren't at all afraid of failing? Once you've identified those things, try to figure out how to go about doing them. Those are the things that are going to matter. From our end, you have my commitment that we will do everything we can to help you to be successful, and also do everything we can to make FETP continue to be the premier program that not only I know it is, but apparently everyone who I run into also knows that it is. That requires the things that Simon was talking about, consistently working on figuring out how we iterate, how we can be better. We are committed to doing all that we can to do that. So in closing, let me just say that you are an absolutely inspiring group of people who are making a difference in the world that truly matters. And I am deeply grateful for all that you do, for the work that you do, and for who you are. So thank you for everything that you've done. Now, I'm excited to introduce our next speaker who's joining us by video, Dr. Bill Foege. Since helping lead the global victory over smallpox, Dr. Foege has taken a leadership role in some of the most important public health issues of the last 40 years. He's been a physician and teacher to the world, especially to the world's less fortunate. Bill Foege has not only been a distinguished director of the CDC and strategic leader of global health programs and institutions, but he's been a committed and consistent teacher and mentor throughout his long career. He has mentored several generations of present and future leaders. He's with us today by video to introduce Becoming Better Ancestors, 9 Lessons from Global Health to Change the World. So over to Bill by video.
Good evening, and thank you for allowing me to say a few words. I've waited many years to be able to say 87 years ago, the journey began ending this evening. So 87 years, and over 70 of those years, I've actually observed global health. Our granddaughter visited us when she was 5 years old, And I said something that made her laugh. And she says, "Papa, you are so funny, but you do not have a brain in your head." And it's because of her diagnosis that I have the courage to talk to you tonight. I went to my first EIS conference in 1962, 61 years ago. I had become interested in global health in high school. So I was a bit surprised when I went to medical school in the 1950s and found very few people shared my interest. It was hard to find someone on the faculty to be a mentor. But I did find one person, Ray Ravenholt, and I began working for him after school and on Saturdays. He was in the second EIS class at CDC, soon after Alex Langmuir arrived from Johns Hopkins. And Ray said to me, "If you're really interested in global health, I would suggest you go to Atlanta, try to get into the EIS program, and you will have friends and colleagues that you will cherish for the rest of your life." And he was right. Another faculty member said to me, "If you really want to go into global health, you will work your entire life and see no change." And he was wrong. Because in my years, I have seen smallpox eradicated. I've seen rinderpest eradicated. I have seen river blindness or onchocerciasis go from a problem across Africa to a very small problem today. And so I have seen programs now for trachoma, lymphatic filariasis, intestinal helminths. I've seen programs to improve what we do in malaria and what we do in other tropical diseases. I've seen programs that have lowered the under 5 mortality rate around the world. I've seen programs that have increased longevity around the world. I have seen the Gates Foundation provide resources that have changed everything. I've seen around the world students in college and universities have become interested in global health. CDC was conceived in global health, with the malaria program and the tropical disease program supporting troops in the South Pacific. It continued with a malaria eradication program, the smallpox eradication program. And despite some statements that you might hear, CDC has always been a response agency, with EIS officers often leaving within hours of a request coming in from a state or from another country. CDC was seen as the jewel in the crown of HHS. And this all changed, of course, with the Trump White House, where he changed what happened to global health and public health and changed what people thought about this vocation. So I'm so pleased that what you are doing now every day is to restore the reputation of public health. The second thing I would like to mention is in 2020, we had planned a 40-year anniversary in Atlanta of smallpox workers to commemorate WHO's declaring the world now free of smallpox. Because of coronavirus, this was canceled, but one of the presentations was to be on lessons from smallpox eradication. Well, there are hundreds of lessons, but we decided to focus on 9 of them. These have now been put into a curriculum called 9lessons.org that you can get free on the internet. It's free for any school in the world to use to look at those lessons and see how they apply not just to smallpox, but to public health in general and to life in general. I divide the 9 into 3 categories. And the first category, things, truisms that you'll understand immediately. The first one is, this is a cause and effect world. It's not a world of magic where you can say the virus will disappear next week. And we try to find those causes in order to impact the effects. The second lesson is seek the truth. And sometimes I can tell you it will be so difficult to have to face the truth. I think back to October of 1973. We did our first search for smallpox cases in India. And I was so naive that in writing up the instructions, I said, we won't find much smallpox because it's the low season of transmission. But what we will do is figure out how to find smallpox. 6 days after we started, in just 2 states, Uttar Pradesh and Bihar, so the searchers had found 10,000 new cases of smallpox. We were overwhelmed, and there were people who said, let's never do this again. But of course, we had to do it again because it was the best surveillance system we had ever had for smallpox, which is why we found so much of it. And so seeking the truth becomes the basis. If you're going to change anything, you have to know what the truth is. The third lesson is seek coalitions. You can't do anything on your own. So you need coalitions at home, in your city, in your county, in your state, in your nation, and in the world. But then there are 3 more lessons that I see as sort of pauses, hesitations, to figure out, are we doing this correctly? And the first lesson in this category is avoid certainty. It was Richard Feynman, the physicist, who in 1963 at the University of Washington said that certainty is the Achilles heel of science. Well, it's also the Achilles heel of politics and of religion and everything else. And so he said, once you are certain about something, you stop searching for another answer or a more complete answer. So avoid certainty. This then leads to evaluating what you're doing and continue to improve what you're doing. So instead of just hoping that the outcome is going to be what you expected, you have to do constant evaluation to know what you're actually seeing, and then use that evaluation to change tactics and sometimes even to change strategy. And the third lesson in this category is respect the culture. We often feel we understand what is happening. We know what to do. But if we move into a community and the community is not ready for that, I can tell you, if you tangle with culture, culture will always win. And so respect the culture. And with these 6 lessons, you're ready for the last 3, which is sort of, how do we go to scale? How do we take what we've learned and apply it every place? The first lesson in this category is to combine science and management. Good science will give you the best answers on what to do, but it's good management that will give you the best results. And so this combination of science and management turns out to be crucial. The second lesson is seek political support. Political support is important because, particularly in public health, we are almost a single-payer system. We're dependent on politicians for our appropriations. And instead of having politicians fighting public health, or as in the case of the Trump White House, belittling public health, we need politicians who are invested in the outcome, that they become true partners to what we are doing. And I try to convince students that they should think about going into politics. Just imagine a Congress made up of public health people and what could happen then. And finally, the last lesson in this category is to think on a global basis. Wherever you are in the world, you're both local and global. So no matter where you're doing public health, you're doing global public health. And we all share the objective then of global health equity. Think of that. 3 words describes our objective. Take away any one of those 3 words and you don't have the same thing. Add 200 words and you don't improve it. Global health equity. That is what we are trying to achieve. Third and last point that I would make, I tell students, you're not likely to get rich and you're not likely to ever be thanked. But if you can get beyond those 2 things, public health and global health are great vocations. So think about doing things because of how gratifying they will be. And keep three things in mind. Try your best to get the science right. You'll make mistakes, but correct them and go back and change the tactics and strategy to get the science right. Thomas Huxley said, science is simply common sense at its best. And so we've all met people who are opposed to science, and yet they think they have common sense at its best. If we can frame things in the arena of common sense at its best, we may convert them while they may not be converted to science. The second thing that Will Durant said we should add to science is art. And he makes the point by saying the first scientist that we know by name in history was an Egyptian physician by the name of Imhotep. He was an artist and a scientist. He designed the step pyramid, and then he overlooked the development and building of the step pyramid. And Will Durant says, if you put those two things together, you now have creative common sense at its best. And I would add one third part to this equation, and that is a moral compass. Go back 700 years and think of Roger Bacon, one of the most enthusiastic scientists in all of history. The Pope asked him to do a summary of science, and in his summary, he displays this enthusiasm. He predicts cars and airplanes and submarines and telescopes. But he says to the Pope, science has no moral compass. And so you have to develop scientists with a moral compass. And when you do that, you now have moral, creative, common sense at its best. That's the best succinct statement of what you are doing. And I'm pleased that you are doing this. In my waning years, I take so much pleasure in seeing every EIS class and seeing what you are doing in order to fulfill what the world needs. So enjoy this evening, and thank you.
Good evening, ladies and gentlemen. I've been mistaken as the Crown Plaza priest today, but I'm actually Carl Reddy. I'm the director of TEFINET. And it is my great privilege to acknowledge a distinguished guest that is with us this evening. He is a champion of FETP. He's a former CDC director, and he's the founder, president, and CEO of Resolve to Save Lives. Welcome, Dr. Tom Frieden. And now it is my pleasure to welcome the moderators for this evening. The first moderator is Ellen Yard, who's an epidemiologist. She works at the Field Epidemiology Training Program team at the Centers for Disease Control and Prevention. Welcome, Ellen. And the second moderator for this evening is Dr. Solomon Corville, who's an FETP monitoring and evaluation consultant with TEFINET, which is a program of the Task Force for Global Health. Welcome, Solomon.
Good evening. I have the pleasure of announcing our first presenter tonight. Dr. Javier Novello is from Belize. He graduated from the Belize Field Epidemiology Training Program. He will present Effectiveness of COVID-19 Surveillance System Implementation, Kobe Foundation, the Belize Central Prison, Belize, September 2020 to 2022.
Good evening. Belize is a small country in Central America with a population of just above 400,000. The Belize Central Prison is the only prison in Belize. It is managed by Colby Foundation, a private non-profit organization that has been contracted by the government of Belize to manage the prison. The Belize Central Prison has an average population of 1,200 inmates with a male to female ratio of 16:1 and 250 staff members. The medical department at the Belize Central Prison consists of 1 medical officer, me, and 5 emergency medical technicians, 1 civilian, and 4 inmates. The Belize Central Prison has different housing locations or housing units where inmates live. Some have their names designated as Tangos 1 all the way through 11. Some are program buildings. We have a youth housing unit and a female housing unit. Belize recorded its first case of COVID-19 in March of 2020. And by April, we started to design a surveillance system. In May, this surveillance system was implemented. And then in June, we started PCR testing by the laboratory for the Ministry of Health and Wellness in Belize. It was not until August when we received some rapid tests and the prison started rapid testing for COVID-19 in the prison. And until September, the Belize Central Prison detected its first case of COVID-19. So we aim to describe the process for surveillance implementation at the Belize Central Prison and to analyze the COVID-19 surveillance system data. So what we did in the prison is we created logbooks for manual data gathering, such as names, onset date of symptoms, and contacts. We also selected specific inmates and trained them to help as surveillance personnel. We then analyzed the data, and we tested for COVID-19. Here, we are looking at the data flow of the distinctive point sources. All housing units, each with a distinctive name and structure where inmates are housed in the prison, were assigned a trained inmate who performed active surveillance by daily screening of COVID-19 symptoms. These inmates did daily in-person questioning and recorded symptoms and reported to the Medic Triage Center on a daily basis. The Human Resource Department and the individual staff with symptoms also reported to the Medic Triage Center for screening. The prison's medical officer then screened and approved candidates for COVID-19 testing via rapid and/or PCR tests, and all the results were recorded in the Belize Health Information System for the Ministry of Health and Wellness in Belize and the Medic Department's database. The prison had a positivity rate of 18%, where the males recorded 19% and the females recorded 15%. With regards to age and gender, the median age was 31 years of all the cases that were detected positive, with an age range of 15 to 66 years. The yearly trend revealed that in September of 2020, we started to see an increase, which was in relation to an increase in the public domain with regards to an Independence Day celebrations in Belize out in the public where staff, prison staff, and officers indirectly exposed the inmates in the prison. This then led to a prison lockdown. And then in the year 2021, we had another increase during the independence celebrations that led to another lockdown. And in 2022, we had at the beginning of the year an increase right after relaxation of the COVID-19 restrictions by the government of Belize in December of 2021. In 2022, we also had another increase of cases in June after what is called the Family Days that was reinstituted by the prison, where entire families were allowed to visit the prison. Here we can see the different locations with their distinctive names. We had Tangos 7 and 11 that had the majority of cases. Tangos 6 did not record any cases. This is our psychiatric unit where movements among inmates is restricted. And we only have one female location. What helped us to manage the COVID was the high rates of the vaccination status. 100% of prison officers and staff were vaccinated, and 88% of inmates received at least one COVID-19 vaccine. So what we did was targeted interventions. For example, Tango 7 and Tango 11 that recorded the highest cases were on complete lockdown for a period of time. The high-profile building has one designated cell, and then we had some program buildings that had each dorm designated for isolation. Tango 2 was our main isolation unit for the prison, for the general population that was separated into convicted and remanded sections. And we designated a buffer zone near the entry point of the prison for all newly admitted inmates for quarantine. So we were trying our targeted interventions, and our protocols were based on the regulations by the Ministry of Health in Belize. Some restrictions included mandatory mask wearing, social distancing by implementing markers on key areas around the prison, installation of hand wash basins in areas around the prison where it was necessary, controlled inmate movement, designation of a buffer zone, and sanitization. So, despite the limited resources in the prison, training and the use of inmates for a COVID-19 surveillance system provided adequate information for data analysis and interpretation for the prison to manage and control the COVID-19 and maintain its functionality, ensuring that all inmates remained safe and secure in custody for the protection of the public and maintaining the prison's mandate. So some key recommendations including to build on the success of the COVID-19 surveillance system and to expand for other communicable diseases, to acquire additional medical staff and provide regular surveillance training, to collaborate with external entities for support on surveillance systems, and to develop emergency response plan for future outbreaks. I would like to acknowledge the partners on this slide. That is the Field Epidemiology Training Program for Belize, the Ministry of Health and Wellness in Belize, CDC Comisca, and of course, the Belize Central Prison. Thank you.
Thank you very much. This presentation is now open for questions. I'm actually going to take the liberty of asking the first question. Can you tell me what is the current status of COVID-19 and vaccination in the prison?
Yes. You bring up a slide. Sorry. So currently, we don't have any COVID-19 case in the prison. After we had our study that culminated in September of 2022, our surveillance system did detect in October an increase of cases. Was around 12 cases, and then in December there was a small cluster for us around 105 cases that we managed properly in 2 weeks, and since January of this year up to April, we have no cases in the prison.
Thank you. So I'll do the first question on the microphone on the left here. And also just a reminder, please only ask one question at a time. And also just to let you know that the people that are listening on the live stream are not able to ask any questions. Thank you.
Bob Chen, EIS 84, Brighton Collaboration. Thank you for that very interesting presentation. Your descriptive epi suggests the Independence Day celebrations are somehow a trigger, and trying to think through that a little bit. Are there any changes within the prison per se, or is it more that on the outside the public is meeting and congregating more frequently, and somehow then kind of the transmission to the prison is a byproduct of that outside interaction? Any hypotheses?
Yes, thank you. So the inmates did not celebrate the independence. There was no celebration in the prison. What happened is that outside in the public, the celebrations, they exposed the staff members. Some staff members travel every day in the prison, so indirectly the inmates were exposed by that celebration out in the public.
Thank you. Microphone on the right.
Sukarma Tanwar, EIS class of 2018, and I'm supporting the FETP program in India. Very good presentation. You showed there were three spikes. Were they all the increase in cases in Tango 7, or did it go around, because you said that most of the cases were in Tango 7, or was it changed during the three spikes?
Thank you. Most of the cases were in Tango 7, but the spikes were not necessarily directly to Tango 7 and Tango 11. It was all around the prison.
Anything that happened in Tango 7? Sorry, can I just a follow-up to that?
Yeah, I can clarify.
Thank you.
Yeah, what happened is that Tango 7 and 11 were the buildings that had more inmates in one location, and they had a little bit of congestion.
Thank you.
Thank you. Microphone on the left.
Thank you for your wonderful presentation, Joanna Gaines, EIS 2010, former FETP RA. I actually had a question about your decision to incorporate inmates as part of your surveillance collection team. Could you share a little bit of information on sort of how that decision was made and how those individuals were selected or trained? Thanks.
Thank you. Well, the Belize Central Prison is a bit understaffed and has limited resources. So in general, to manage the entire prison, we depend on inmates. So we already have a screening method for inmates that are selected for work. So when we started to develop the surveillance system for COVID-19, we processed our screening methods for working inmates, and that is how we selected the inmates that we trained to help us in this surveillance.
Thank you. Microphone on the right.
Thank you very much for your good presentation. As I told you, my name is Dr. Angela Limo. I am an American citizen, even though I am coming from Tanzania. I want to think outside the box, and this message I want it go for your director, and the second message is specifically go both for you and for your director too. When I listen to the old physician man, they are telling us 3 points we needed to work on it. I want to advise a recommendation that then you needed to combine. You needed to combine. He said management, leadership, and science. You need to combine with physicians who, like us, World Bank, produce the course called Essential Public Health Function and Leadership. We who graduated like me, you need to combine essential leadership, strengthening public health leadership with this program of FETP. We can come out with something called EFETPL, Essential Field Epidemiology Training Program and Leadership. We can sit down and redesign framework of the restructure so that we can upgrade America. That's the first point. The second point, he spoke about coalition.
I'm sorry, do you have a question?
Yeah, that's what I'm coming to. He spoke about coalition that involve political, but I want us also in this training program to think about to involve those pop star. When I mean pop star, they are like musician, like ambassador, because they have viewers like 15 million, 11 million, 13 million. So when we initiate a program of awareness, when they send one message, it reaches 15
I do need
million
you to get
people.
to the question, please.
Yeah, thank you. I appreciate that. So I appreciate also for your presentation.
Thank you.
All right.
Okay, thank you. Please only come to the microphone if you have a question. On the left.
Okay, yeah, thank you. So my name is Jose Montes. I am from the Field Epidemiology Training Program in Mexico. And well, first of all, I wanted to commend you on actually training the inmates for the surveillance program that you implemented. So regarding to that, my question was, what were some of the difficulties that you found during the training of these inmates that you could share with us, so that if we are implementing a similar surveillance system in an enclosed setting, we would take them into consideration? Thank you.
Thank you. That's a very good question. One of the major difficulties that I faced with selecting the inmates or training the inmates is that I had to consider the level of education of some inmates. I had to consider their security risk levels, and I had to consider their overall interest to work in the health department. Because if you have someone that does not have an education level to read and write, then they would not be the ideal surveillance officer or assistant for you. So if you consider the security level, the education level, and I would even go as far as considering their time in the prison. If they're serving a lengthy time, it would be easier for them to be one of your surveillance officers.
Thank you very much. We are actually at time for questions, so congratulations. Thank you for a wonderful presentation.
Good evening, everyone. The next presenter will be Ms. Saya Gazezova. She's from Kazakhstan and graduate from the Central Asia Advanced Field Epidemiology Training Program. She will present Salmonella enteriditis outbreak at a wedding event, Kazakhstan, June 2022.
Good evening. In Kazakhstan, in a city of 130,000 inhabitants, 50 people were hospitalized from June 13th to June 16th with gastrointestinal illness. All hospitalized people had either attended the same wedding on June 12th or had eaten leftover food from that wedding. The source of the illness was unknown. Residents from the Central Asia Field Epidemiology Training Program, pictured here and including myself, were assigned by the Ministry of Health to conduct an investigation, identify the source, and prevent further cases. We conduct this search for additional cases. We looked for reports in healthcare facilities and the health departments. Our case definition was people who had attended the wedding or consumed leftovers and became ill over the following week, with symptoms of fever, abdominal pain, diarrhea, nausea, and vomiting. We identified 182 people who had either attended the wedding or eaten food from the wedding. Of these 182 people, 76% consented to be interviewed. Of the 138 participants who consented, 48% had become sick. Of the 66 people who became sick, 45% had only eaten leftovers and had not attended the wedding dinner. The most common symptoms reported by the 66 people who had become sick were diarrhea, abdominal cramps, and fever. Symptom onset was rapid. Symptoms developed from 6 hours to 4 days after the event. Cases peaked within 2 days of the event, as shown here in this histogram. By the time our investigation began, cases had subsided. We used log binomial regression to determine which foods were independently associated with illness. In bivariable analysis, we found that people who had eaten cake and people who had eaten leftovers had higher risk of being sick. Those who ate traditional meat noodles, samosa, and chicken had reduced risk. The attack rate for the 52 people who ate leftovers was 81%. The attack rate for the 68 people who ate cake was 87%. Leftovers from the dinner had been eaten by only 45% of sick people and by 11% of people who did not get sick. By comparison, wedding cake had been eaten by 89% of sick people, but by only 13% of healthy people. We conducted multivariable analysis and looked for potential interactions between foods. We found no interactions. Cake was the only one food product that remained significantly associated with illness. People who had eaten cake had 7.8 times greater risk. Leftovers, meat noodles, samosa, and chicken were not associated with illness. So next, we tried to gather more information about the wedding cake. We learned that a total of 14 homemade cakes were served at the wedding. The cakes had been prepared 2 days before the event at somebody's house. The cakes had been stored and transported at room temperature. To identify a potential source pathogen, we obtained stool and gastric lavage samples from the 50 sick people that had been hospitalized. Among sick people tested, 70% had Staphylococcus aureus detected in their samples. And Salmonella enteritis was isolated in samples from 98% of sick people tested. Salmonella enteritis was also isolated from wedding cake. The wedding cakes were traditional honey cake. Raw eggs are one of the ingredients used in making honey cake. They are mixed with cream and layered between cake. The layers of cream in a typical honey cake are pictured here. Salmonella is commonly found on eggs, and salmonella-contaminated eggs have also implicated in several large foodborne outbreaks globally. Giving out of leftovers, or sarqat, is a common tradition in Kazakhstan. Sarqat usually includes mostly leftover sweet food from an event. Cake had been included in the leftovers given out the wedding dinner. The images shown on the left and right are actual images from the sarqat containing cake given out the wedding. Onset time of 6 hours to 4 days were more consistent with Salmonella enteritis than with Staphylococcus aureus. The top 3 reported symptoms were also more consistent with Salmonella. Additionally, Salmonella was detected in both cake and patient samples. Staphylococcus aureus was only detected in patient samples. Unfortunately, our investigation is limited by the inability to directly link cake to patient strains. Sequencing is not available in Kazakhstan, and it is not used in foodborne outbreak investigations. We also don't know what foods were eaten by the 24% of people who did not consent to the study. But we do know that most of the people who did not consent were relatives of the bride and groom, and that they were concerned about legal implications related to the outbreaks. The person who prepared the cake was also a relative of the bridal couple. All persons with any leftovers from the wedding were advised to discard them. Persons were also advised to seek medical care if they developed any symptoms. Recommendations were made to the restaurant to ensure compliance with food safety measures. These include not allowing serving of home-prepared foods where it is not possible to observe compliance with hygiene and sanitation regulations. No additional cases were detected, nobody died, and all ill persons recovered. And we heard that bride and groom are still married. We also we hope they will live happily ever after. Thank you.
the presenter need translation. The presentation is open for question now. I think the resident advisor from Kazakhstan, maybe she will try to translate the question. Please, one question by person.
Hi, thank you for your very detailed, wonderful presentation. I'm Shou Wu, EIS 2013 and former Taiwan FETP advisor. My question is, you mentioned, I think so, you did mention Staph aureus. So what kind of specimens were that from? And how did you exclude the possibility, or maybe it's a mixed Staph aureus and Salmonella infection outbreak?
Получается, золотистый стафилококк, он был обнаружен в промывных водах желудка. Мы исключили то, что это не золотистый стафилококк вызвал данную вспышку тем, что для сальмонеллы это более было характерно, симптомы данной вспышки были более характерны для сальмонеллеза, то есть для сальмонеллы, чем для золотистого стафилококка, потому что для золотистого стафилококка более характерна взрывная рвота, и также инкубационный период более быстрее происходит. Данной вспышки у нас было начало заболевания от 6 часов до 4 дней, то есть это более характерно для сальмонеллы.
So the Staphylococcus aureus was detected in human samples, gastric samples. We excluded that from as the main cause of the outbreak due to clinical symptoms. The symptoms were more relevant to Salmonella, and with Staphylococcus aureus, if there was the case, we would see more cases with vomiting, and the incubation period would be much faster. In that case, we saw it up to 4 days. 4 дня, да, было? Up to 4 days, yeah.
Thank you.
Thank you very much. Kristen Van Derendy, FETP Resident Advisor at CDC India. Very much appreciate this presentation. My question relates to your definition of leftovers. If you could give more insight into that. Specifically, was leftovers eating any food, or did you look at specific foods that they ate as far as leftovers? Thank you.
Leftovers, что это такое? Дайте определение leftovers. Что туда относилось, и конкретно расскажите.
Leftovers, получается, это у нас саркыт, это наша традиция в Казахстане. Обычно у нас берут сладости, это с мероприятия. В данном случае также могут брать различные другие блюда, и горячие блюда, и также сладкое, но в большинстве случаев берут сладости. В данном случае у нас в данной вспышке брали для саркыта это торт в основном, сладости это печенье, конфеты, также брали баурсаки. Баурсаки это тоже наше традиционное блюдо в Казахстане. Также брали фрукты, как вы можете видеть на данных картинках справа и слева.
So the example of leftovers is presented on these pictures. It's the traditional way of, like part of tradition. Sarkit includes any kind of dishes from the table. But in this case, it was mainly sweets. So the interview was really included the questions, what it was what people were taking. And you can see that it's really vegetables, fruits, and cake was in all of these leftovers.
Хотела еще добавить, на данной свадьбе было, что именно количество тортов было очень большое, в количестве 14 тортов. Я думаю, из-за этого очень много людей взяли данный продукт для саркыта с собой.
So for the wedding, there were 14 cakes prepared by the family, and it's basically the main things that went into all the leftover parts into the bags for the guests. Thank you.
Thank you.
John?
Hello, John Watson, EIS 2002. Thank you for a very nice presentation. One question, you noted the cakes were homemade cakes, 14 homemade cakes. I'm wondering, was it the same kitchen that these were prepared in, or were they separate kitchens such that you could differentiate maybe in your analysis in terms of the risk associated with the cake? Thank you.
Вы сказали, 14 тортов приготовлены дома. Они были приготовлены на разных кухнях или нет? Это учитывалось в анализе? Или это одна кухня, где готовились торты?
Для данного мероприятия, для свадьбы, использовалась только одна кухня. Это человек, который готовил данные торты в количестве 14 штук. Это была родственница организатора свадьбы. И она готовила данные торты в домашних условиях на своей кухне, получается.
So all 14 cakes were prepared on one kitchen. It's one of the relatives of the bride and groom were cooking in just one place.
Thank you.
Kip?
Hi, Kip Baggett, US CDC, former FETP resident advisor in Zambia. I've never had the privilege of traveling to Kazakhstan, so I've never been there. I hope to go someday. The honey cake looked delicious, but I'm not sure that I should eat it if it's routinely made with raw eggs, if the icing is made with raw eggs. I wonder, in addition to the recommendations that you made to the restaurant, is there a place, if honey cakes are routinely served at weddings, is there a place for a broader public health intervention about alternatives to raw eggs for making honey cakes?
Помимо тех рекомендаций, которые вы дали для этого конкретного мероприятия, и медовые торты используются так активно во время мероприятий свадебных, есть ли какая-то рекомендация заменить сырые яйца на какой-то другой продукт?
Конечно, можно заменить на другие продукты. Это, возможно, другой крем, возможно, с творожным сыром. Да, это вполне возможно. Спасибо за рекомендации. Нет.
So it's a great recommendation. There is a possibility to make a substitute for the raw eggs. That was not really proposed in this investigation, but thank you for the idea.
Thank you.
Thank you.
I think we have 30 seconds. I want to ask one question. I'm a little bit curious to know if you conducted some environmental survey for this evaluation. If so, yes, if you can please give some more details on that.
Так, образцы с окружающей среды были взяты, но никаких патогенов не было обнаружено.
Yes, there was environmental sampling testing, but non-pathogens were detected. So everything was negative.
Thank you.
Our next presentation will be from Mr. Daouda Kamara. He is from Sierra Leone, and he graduated from the Sierra Leone Field Epidemiology Training Program. He will present high COVID-19 vaccine hesitancy among the general population, Freetown, Sierra Leone, 2022, a community-based cluster survey.
Thank you. Good evening, distinguished ladies and gentlemen. This slide shows the COVID-19 situation in Sierra Leone. On March 31st, 2020, Sierra Leone confirmed its first COVID-19 case. Following this confirmation, the government of Sierra Leone, through the Ministry of Health and Sanitation and its development partners, took several interventions to stop the spread of COVID-19 virus, including the introduction of COVID-19 vaccine in March 2021. Despite the introduction of the COVID-19 vaccine, Sierra Leone continues to experience a high number of COVID-19 cases and deaths. In a bid to interrupt the rapid rise of COVID-19 cases and deaths, the government further implemented COVID-19 vaccination surge on June 14, 2021. This was an initiative geared towards increasing the vaccination access in every part of Sierra Leone. Despite all these efforts, by end of November 2021, prior to our study, the vaccination coverage within Sierra Leone was at 40%, which was below the WHO recommended 70% vaccination coverage threshold. Following our study and dissemination of findings to the Ministry of Health and Sanitation, coupled with other public health interventions, by end of March 2023, the vaccination coverage was at 79%. As of April 25, 2023, Sierra Leone had recorded a total of 7,762 cumulative confirmed COVID-19 cases and 126 deaths. This slide shows the factors associated with COVID-19 vaccine hesitancy according to literature reviewed and the objective of our study. According to several pieces of literature reviewed, vaccine hesitancy is attributed to mistrust, safety, and low education. We aim to determine the COVID-19 vaccine coverage and factors associated with vaccine hesitancy among the general population in Freetown, Sierra Leone. This slide and the next to follow will show the method we used to obtain our study findings. We collected data in May 7 to 14, 2022. We used a multi-stage sampling technique, and we recruited and interviewed 367 household heads that were above 18 years. We used EpiInfo7 software to perform the analysis. During the analysis, we perform univariates by computing frequencies and proportions. We also perform bivariate and multivariate analysis by computing crude oil ratios, and the study findings were statistically significant at a p-value less than 0.05. This slide shows the definition of key terms: vaccine hesitancy, slum and non-slum settlements used in our study. According to the Strategic Advisory Group of Experts on Vaccination, they define vaccine hesitancy as a delay in acceptance or refusal of vaccination despite the availability of vaccination services. And this greatly undermines the control of COVID-19. The United Nations also defined slum and non-slum settlements as, and for slums are informal settlements characterized by the lack or limited health, education services, limited spaces, insecurity, and informal jobs or no jobs. Whereas for non-slums, they are formal settlements with improved access to health services and amenities. I will now take you through the results of the COVID-19 vaccine coverage and hesitancy that's occurred in the slum and non-slum settlement in Freetown, Sierra Leone. 30% of the respondents were within the age group 25 to 30 years. The median age was 35 years, and it falls within the range of 18 to 91 years. 55% of the people interviewed were female, and 52% were married. This slide shows a proportion of respondents who were hesitant compared to those who were non-hesitant. 40% were hesitant to take the COVID-19 vaccine compared to 60% non-hesitant. This slide shows a comparison between respondents who were hesitant and those who were non-hesitant in both slum and non-slum communities. We observed that 44% of the respondents who were hesitant to take the COVID-19 vaccine were residing in a formal or non-slum community compared to 38% living in informal or slum community. There is not much difference between the two settlements. This slide shows the reasons for COVID-19 vaccine hesitancy. According to our study, 32% were worried about unknown future effects. 26% were worried about side effects. 19% don't trust the COVID-19 vaccine. 13% of the respondents said that the COVID-19 vaccine was ineffective in protecting themselves from contracting the disease. And 7% said the COVID-19 vaccine is unsafe to them. And 1% said because of cultural and religious beliefs or reasons. Two factors. This slide shows the COVID-19 vaccine hesitancy associated factors. From our findings, two factors were statistically significant, and the respondents who said the COVID-19 vaccine was safe, and those who said they would recommend the vaccine to their families and friends were less likely to be hesitant compared to those that don't believe the vaccine was safe and should be trusted. In conclusion, generally, 40% of the respondents were COVID-19 hesitant. Vaccine hesitancy was associated with unknown future effects, side effects, and limited protection. When we did our study, we presented these findings to the Ministry of Health and Sanitation together with its health development partners. From our findings, many community-based public health interventions were conducted, and the Ministry of Health and Sanitation established a surge campaign in a bid to increase the COVID-19 vaccination coverage. And then they also intensified community sensitizations and health education campaigns. And then they also strengthened collaboration with partners. We recommended the following to the Ministry of Health and Sanitation, and some of these recommendations had already been implemented, where some of them, it is still being done currently, for them to be able to reach the 90% national COVID-19 vaccination coverage. I would like to acknowledge the following institutions for their invaluable support throughout our study, and I want to thank you all for your attention.
Thank you. This is now open for questions, and I will take the liberty of asking the first question. What has happened since your study? What's the current vaccine hesitancy and coverage?
Since we conducted this study, initially before we conducted the study, it was at 40%. Currently, it is now at 79%. And then the vaccine hesitancy has drastically reduced, and then we have seen an increase in the COVID-19 vaccination coverage. And then for Western area urban, where we did this study, the vaccination coverage is at 87% currently.
On the left?
Bob Chen, Brian Collaboration. Our collaboration focuses on advancing the science of vaccine safety, so your talk is very interesting. At one level, Sierra Leone is a natural experiment because in 2015, you had the Ebola outbreak, and with 11,000 deaths, I just looked that up on Google. And the vaccine that was introduced actually had a lot less safety data compared to the COVID-19 vaccine that in general had much larger trials, about 40,000 people in these trials, and used in high-income countries with a lot of safety data before introduction in low and middle-income countries. So it's interesting that there seems to be this perception in Sierra Leone of lack of safety at the beginning of your survey, even though the truth in reality is totally different, I would argue. And so I'm just kind of curious, are you able to kind of contrast why the Ebola vaccine was accepted in Sierra Leone compared to the COVID vaccine?
For Ebola, when we had Ebola, it was a novelty, and as we were responding to the Ebola outbreak, we were learning as we are moving forward. But when we had the COVID-19 outbreak, a lot of misinformation had already been disseminated to various social media platforms. And within Sierra Leone, majority of the population are young people, and then they have access to WhatsApp, to Facebook, and all those things. So when they saw some of those misinformation, they were a little bit skeptical or doubtful not to take the COVID-19 vaccine as compared to the Ebola vaccine.
Thank you. On the right?
Thank you for the good presentation. Sukarmat Anwar from USCDC India office. When you started you were explaining your case definitions, you did talk about slum and non-slum settlements. But when you went in, and I was expecting that you will be showing what were the differences in people taking vaccines from slums and non-slums. You did mention about hesitancy, but when you went to the reasons, we did not, we thought like because of access to education or access to healthcare, there would have been some difference. Can you discuss if there was some starking, like differences between the two with regards to the reasons for uptake? Thank you.
For the two settlements, there was not much difference between the two in terms of vaccine uptake or coverage. But we observed that within the non-slum, we had more respondents that were hesitant to take the COVID-19 vaccine as compared to the slum. Because for non-slum, it was 44% as compared to the slum, which was at 38%. So there was not much difference. And also, when we went further to the slum, because we interviewed 367 respondents, and out of that, 148 came from the slum settlements. And from the slum settlements, only one respondent was fully vaccinated as compared to 5 that was partially vaccinated. So that shows as compared to the non-slum settlements that had high number of respondents that haven't taken the COVID-19 vaccine. But even though there was that difference between the two, but there was not that much difference in terms of vaccine coverage.
I was trying to understand the reasons. Were the reasons for non-vaccination same, or the reasons differed in the two settlements?
The reasons were the same.
Okay.
The reasons were the same for the two settlements. The first was they were worried about unknown future effects. And then the second was they don't trust the COVID-19 vaccine. And then the third, they said it was because it was ineffective in protecting themselves from contracting.
Thank you.
Thank you. On the left.
Yeah. Hi, Jose from the Field Epidemiology Training Program in Mexico. So first of all, congratulations on the work that you presented. And my question was, why did you decide to define a new variable, which was vaccine hesitancy? How did you define that variable, and why didn't you consider using already, like let's say, more objective variables such as the vaccination status instead of creating a new variable? Thank you.
We reviewed literatures from various articles, and then we got the definition from one article that we read. And according to the Strategic Advisory Group of Experts on Immunizations, SAGE, S-A-G-E, they define vaccine hesitancy as a delay in vaccination or refusal to access vaccination services, even though it is accessible or available. And then our focus was on two key objectives. One was for us to determine the current COVID-19 vaccination coverage. And then the second for us to look at the factors contributing to the vaccine hesitancy in Freetown, Sierra Leone.
All right, we're just about at time. We'll do one final question on the right.
Thank you. My name is David Sniadak, formerly FETP resident advisor in Peru from 1993 to 95. And I had visited Sierra Leone during the Ebola outbreak to help with planning a measles campaign, actually, and was very impressed with the capabilities of the ministry there. You know, normally when we have a problem of failure to vaccinate, we look at two things. We look at client-based reasons and provider-based reasons. And you've clearly focused on potential client-based reasons in terms of their vaccine hesitancy. Two questions. One, I wonder, was the coverage in the slum area different than the coverage in the non-slum area? You mentioned the vaccine hesitancy was roughly similar. And second, did you evaluate at all potential issues regarding provider-based reasons? You did mention in the slum areas, for example, there's less access to health services. Or there are any number of reasons, actually, provider-based reasons. Maybe they ran out of vaccine. There was a problem with the cold chain, all sorts of reasons. I was wondering if you evaluated that as well.
We looked at those reasons as well. The COVID-19 vaccines were available, and most of the respondents also knew where, if they want to access these COVID-19 vaccines, where they should visit. And then for the client base, for our study, we only looked at the client base responses because the COVID-19 vaccination coverage was at 40%, and we were below the 70% WHO recommended threshold. So we had a lot of rumors that the participants were hesitant to take the COVID-19 vaccine, and then the coverage was low. So that was why we decided to conduct this particular study. And then for the slum and non-slum settlement, as I earlier said, there was not much difference, but we observed that for the non-slum, the hesitancy was higher, which was at 44% as compared to the slum, which was at 38%. And then for the slum, out of the 148 respondents that were vaccinated, that had already taken the COVID-19 vaccine, we observed that one of them had fully taken the COVID-19 vaccine as compared to 5. And then for the non-slum, we also observed that and out of the 248, 5 of the respondents were partially vaccinated as compared to 163 that had already taken the COVID-19 vaccine fully. So, but there was not much difference. That was why we didn't present it in our findings.
Okay, we need to wrap this one up. Thank you so much. Congratulations.
Our next presenter will be Mr. Moses Jiru. He's from Kenya and graduate from the Kenya Field Epidemiology Training Program, and will present the viral suppression outcomes among adolescents and young people and antiretroviral treatment in a rural setting in Katanga Sub-County, Kenya 2022.
Thank you. Good evening. Globally, in 2021, that 8.4 million people were living with HIV, with more than 2/3 in African region. In Kenya, it was estimated that there were 1.4 million people living with HIV. In Gatanga sub-county, located in Murang'a County, central Kenya, there were estimated 3,540 people living with HIV. UN aims set ambitious targets in December 2020 of ensuring that 95% of people living with HIV knew their HIV status, 95% of PLHIV were initiated on ART, and 95% of those started on ART achieved viral suppression by 2025. This is in line with the goal to eliminate HIV AIDS by 2030 as a public health concern. Viral suppression is a key indicator of antiretroviral treatment success, and testing is indicated every 6 months for those 0 to 24 years old. Previous Kenyan studies and surveys documented gaps in the achievement of UN's target on viral suppression. In 2021, 42% of new adult HIV infections occurred in 15 to 24 years old in Kenya. Poor viral suppression is more likely in adolescent and young people on ART compared to adults with the likelihood of developing treatment failure associated with increased morbidities and mortalities. There were limited studies on viral suppression outcomes among adolescent and young people on ART in a rural setting. We aimed to determine viral suppression outcomes among adolescent and young people on antiretroviral therapy in Gatanga sub-county. This map shows all the 6 health facilities offering comprehensive HIV care and treatment, which were included in the study, with a total of 230 adolescent and young people living with HIV as of April 2022. We carried out a retrospective record review among adolescent and young people aged 10 to 24 years old, and the inclusion criteria was those who were active on ART, and the ones active on ART were defined as clients who collected antiretroviral drugs in a place they regularly pick them, or asked drugs to last them between period of review. The other inclusion criteria was they needed to be on follow-up for at least 6 months, and they had to have the last viral load recorded. We abstracted clinical data from Kenya Electronic Medical Record System using data abstraction sheet, and we analyzed the data and we were able to get the mean, standard deviation, frequencies, and proportion. For bivariate analysis, we got the prevalence odds ratio and 95% confidence interval. The outcome variable was viral suppression, and those virally suppressed were defined to be the one with viral load of less than 1,000 viral copies per ml of blood. We abstracted 195 records of adolescent and young people on ART, and the graph shows age and sex distribution. The y-axis shows the percentage, and the x-axis shows the age group in years. The blue bars represent females, and the orange bars represent males. Adolescents, that is 10 to 19 years, were the majority at 70%, as highlighted in red. And this could be indicative of successful prevention of mother-to-child transmission of HIV and care and treatment programs, with children who have HIV surviving longer. Females were 61%, which was twice the number of males. The table shows the rates of viral suppression across the 3 age bands, with those 10 to 14 years having a viral suppression rate of 88%, those aged 15 to 19 years, 95%, and those aged 20 to 24 years, 86%. The overall viral suppression rate was 90%, which was below the UN target of 95%, which is to be achieved by the year 2025. The bar graph shows the duration since last viral load, with the y-axis showing percentage and x-axis showing the duration in years. The national guideline considers a valid viral load test to be the one done within 1 year. Only 39% of abstracted records had viral loads done within the recommended period. The reason most, that is 61% of viral loads were older than 1 year was largely due to the national stock out levels of viral load reagent experienced in the previous year. And this could have led to missed opportunities for intervention. The figure shows ART regimen distribution amongst adolescent and young people on ART. Among the 195 abstracted records, 86% were on first line, while 14% were on second line of ART regimen. Among the ones on first line ART regimen, dolutegravir-based regimen were predominantly used at 98%, which was indicative of adherence to national guidelines on ART treatment optimization. The listed drugs, it's good to note that they are not used as monotherapies, but as combination of at least 3 antiretroviral drugs. The figure shows factors associated with viral non-suppression, with the y-axis showing the odds ratio and x-axis showing the factors assessed. Being on second-line ART regimen had 5 times the odds of non-suppression compared to those on first-line of ART regimen. This occurs especially if the barriers which led to the first-line treatment failure were not addressed. National guideline recommends enhanced adherence counseling for at least 3 months before a switch from one regimen to the other. Being on protease inhibitors or non-nucleoside reverse transcriptase inhibitor-based ART regimen had 3 times the odds of viral non-suppression compared to those on DTG-based ART regimen. This supports the evidence that DTG efficacy in achieving viral suppression as guided by WHO 2018. We concluded that viral load suppression was suboptimal among adolescents and young people on ART. Less than half of adolescents and young people had valid viral load results, and viral non-suppression was associated with being on second-line ART use, second-line ART. Use of protease inhibitors or NNRTI-based ART regimen other than DTG-based ART regimen. The recommendation, we recommended strengthening programs and activities supporting adolescent and young people on ART to achieve and sustain optimal suppression, such as Operational 3.0, which advocates for zero missed appointment, zero missed doses, and zero viral load among the adolescent. ART optimization, which is use of regimens which are most efficacious, easy to use, and with higher genetic barriers.
Thank you, Mr. Moses. Like, it's time. This presentation is open for question now. Please come on the microphone. One question per person. I have the first one. It seems that you show in your background that, according to UNAIDS, you have to achieve 95% for viral suppression. But in the county where you conducted this study, and then you have, 80%, 90%, what strategies that you plan and then to have and then to achieve the 95% by 2025? And we are in 2023 now.
Yes, we are very optimistic that by 2025 we'll be able to achieve the 95% viral suppression, given the investment which has been put in place by the county government of Murang'a to ensure that the adolescent and young people achieve viral suppression.
Thank you.
Thank you. Sukarma Tanwar from CDC India. I have two questions, but I will speak to one. Just going on the slide that you have. You talk about in recommendations, missed appointments, missed doses, and viral load. But we could not see anywhere in your results that what proportion of people, like the viral suppression that was happening, was because of missed appointments or loss to follow-up. Is that a serious problem in the country?
These were suggested methods which could assist us in achieving and sustaining viral suppression. And after giving feedback, we have been able to have things like psychosocial support groups and targeted messaging for the adolescent and young people.
Could it be also because people were not on treatment because suppression takes around 12 months. It takes between 7 to 12 months of treatment. Because you never mentioned about how long people were on treatment. Could it be that they were not on treatment for that duration?
Viral suppression with the current regimens, which are very efficacious, like DTG, is being achieved within 3 months. 3 to 6 months, we are able to achieve viral suppression.
Thank you.
On my right.
Okay. Thank you for the very nice presentation, Shewu EIS 2013. My question is that you have in your conclusion you found that PI and NNRTI-based therapies are associated with non-suppression. And you have the recommendation here, it's a ART optimization, but I'm just wondering, could the non-suppression is more associated with non-compliance? So that's created some kind of selection bias that physicians would less likely to prescribe a second-line ART because they are aware that the patient is actually not compliant to the therapy. So that caused their non-suppression. They're hesitate to prescribe the second line instead of the that it was probably not because of the ART regimen that caused that lung suppression. So could you expand and clarify that point? Thank you.
I did not get the question.
Can you repeat, please?
Yes. So the association you found in your study were NRTI and PI based were associated with more patients with non-suppression. So could the non-compliance is some kind of interaction played in this instead of just the causality that the first line is associated with non-suppression?
Thank you. And non-adherence to treatment contribute to treatment failure. But in our study, what we were able to find is that PI and NRTI-based regimen, other than use of detingin-based ART regimen, was associated with viral non-suppression. We did not examine the adherence issues. Thank you.
Okay, thank you.
On my left.
Thank you for your very nice presentation. A decade and a half ago, I was with American Doctors Alliance working in Makerere University, Mulago, Uganda, where HIV started. And we pick up a challenge which will affect not to eliminate HIV 2030, and the challenge which can also maybe contribute there too is a patient, or I cannot confirm a patient, who are discordant couples. I want to explain a little bit about that. Discordant couples is one partner is negative, even if you do ELISA test, Western blot, all kind of tests, he will remain negative, but one is positive. How do we know them is when the wife gets pregnant, we come and test them during the pregnant, and we find she's positive, but when we call the husband, he will still appear negative. I would appreciate, I don't know how much you go far for that research, or CDC can help. Thank you.
The group we studied was the one aged 10 to 24, and we never went into issues of discordance.
Reina?
Reina Tercios, EIS class of 2001, former resident advisor to the Central America FETP. Such an important work and such a challenge to get to these adolescents and young adults. Did the route of transmission of HIV or did the duration of treatment of HIV play any role with the success in getting to viral suppression or with adherence to medications? Were you able to look at that in the chart review portion of your study?
No.
The time is over. Thank you. Very nice presentation.
Our next presentation will be from Miss Maria Casmira Maramag. She's from the Philippines. She graduated from the Philippines Field Epidemiology Training Program. She will present mental health assessment among healthcare workers in a tertiary COVID-19 referral hospital, a cross-sectional study, Philippines, September to November 2021.
Thank you. Good evening. Evidence of short and long-term negative effects on health workers' mental health has been observed in previous communicable outbreaks. To name a few, SARS for PTSD and depression, H1N1 for stress, and MERS-CoV for anxiety and stress. COVID-19 pandemic challenged not just our health systems, but also our way of living during lockdowns and isolations. In March 2020, impact of COVID-19 across 31 countries showed prevalence of mild to severe depression, 53%, and anxiety of 63%. The study site was a 600-bed government hospital located in Metro Manila, the epicenter of COVID-19 in the Philippines. It is a general hospital known for trauma and COVID-19 referrals. There are 1,712 health workers. As of October 2021, 967 had COVID-19 infection with 5 mortalities, case fatality rate of 0.52%. This study aims to assess the mental health status of health workers by identifying presence of mental health program or MHP, determining awareness of MHP, measuring mental health status, and identifying perceived stress and motivational factors. This was a cross-sectional study. 213 completed responses among 267 invited health workers. A list of employees was used in systematic random sampling. Online interviews were using standard questionnaire was done. 2 MHP coordinators were asked about their pre-existing activities on mental health. Health workers were profiled based on social demographic, health, and COVID-19 exposures. 2 adapted tools were used, Depression, Anxiety, and Stress Scale 21, or DAS-21, by Lovibond and Lovibond, for measuring emotional states, and a Likert scale tool from Kai et al. To determine perceived factors to stress and coping mechanisms. Mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well, work well, and contribute to their community. This study measured self-reported emotional states and does not serve as a medical diagnosis, wherein depression felt hopelessness, devaluation of life, lack of interest or involvement. Anxiety felt autonomic arousal, skeletal muscle effects, situational anxiety, and subjective experience of anxious affect. And stress felt difficulty relaxing, nervous arousal, being irritable, or easily upset or agitated. Those who had a total score of 10, 8, or 15 for depression, anxiety, and stress respectively were considered with findings. Prevalence were presented as number and percentage. Multivariate analysis was used to compute odds ratio of profile and DAS-21 findings. Those with p-value of less than 0.05 were statistically significant, and the Mann-Whitney U-test was used in analyzing Likert scale. What we found out, the hospital wellness program started in 2019 after the mental health law was passed. MH coordinators aim to increase awareness and reduce stigma on mental health. In February 2020, a guideline was released on establishing mental health programs in public sector. After a month, the hospital started the Mental Health and Psychosocial Support for, or MHPSS, with the following programs. Conducted mental health awareness seminars, established telekamustahan where they send messages to identify the need for psychological support, provided grief counseling for the workmates of the one suicide case. 7% were aware of the implemented MHP. Most known program was the telekamustahan. 151 or 71% were females, age range from 22 to 63 years old, median of 35 years. More than half of the respondents live in Metro Manila, live with their immediate family, and were college graduates. By occupation, most were nurses, and lowest proportion were doctors. More than 60% were willing to seek professional help. Low proportion of 6% had undergone consultation. 3% have previously been diagnosed with a mental health condition. Per emotional state, there were 16 or 8% stressed health workers, 36 or 17% depressed, 59 or 28% anxious. Collectively, 1/3 or 33% had at least one finding. So you may notice the lack of yellow icon. It is because those who were stressed occurred in combination with anxiety, colored in green, or both anxiety and depression, colored in black. Health workers with previous COVID-19 infection had 3 times more likely to be depressed than those who do not. The odds of depression were 3 times more among those who are willing to consult a psychiatrist, were doctors, or part of the younger population. Lower odds of getting depressed and anxious were seen among those who live in a big household and with their relatives, respectively. Stress group perceived factors to stress were significantly different with the not stressed groups. So exhaustion and having COVID-19 symptoms were identified individual or physical factors. The idea of oneself or others getting infected and report of new cases were examples of social stress factors. Lack of manpower, equipment, and other resources working overtime and felt nervous in the ward contributed to the stressful work conditions. The not stressed groups had significant higher means on factors that help reduce stress, such as positive attitude from workmates and knowing available hospital support. Top coping mechanisms were following strict infection prevention control measures, communication with family and friends, and learning about COVID-19 prevention. We conclude that prevalence of emotional states of depression, anxiety, and stress among health workers were higher at 33% compared with the data in 2020 among Filipino general population at 16%. The associated and perceived mental factors identified were an interplay of biological, social, and psychological factors. The COVID-19 pandemic was a stressful event. Health workers, as responders, had an increase in exposure to the disease, increased workload, and were continuously adjusting due to the uncertainty brought by the pandemic. Protective factors may be enhanced, such as good interpersonal relationship at work and ensuring protective measures are in place to prevent COVID-19. Wide difference on willingness and actual consultation for professional help may be due to the stigma. Contrary to the most studies that willingness was a protective factor, health workers may have recognized the need for support because of existing symptoms rather than preventive way of ensuring wellness. That is why it is important to decrease the gap on MHP, because even if services were available, the lack of awareness may cause low utilization of services. With these, the following actions were recommended. Preventing mental health issues through advocacy programs such as support groups and preventing stigma, reducing stress factors such as assigning safety officers for strict implementation of infection prevention measures, and communicating management available support. Encouraging co-workers, friends, and family to refer observed negative emotional states, and regular gathering of data by including mental health assessment for new employees and inclusion of this service during annual physical exam. Increase awareness and utilization and ensure sustained availability of mental health program. After the study, advocacy programs were conducted, distributed flyers to provide schedule of in-house psychosocial support and national crisis hotline. 58 study responded had psychotherapy. Psychologists announced clinic hours and services during flag ceremony. Findings of the study and the behavioral design program of the Department of Health and WHO were used as background for the implementation of the Public Health Unit's Mental Health Resilience Program proposal with the hashtag Address the Stress Together. The hospital management approved implementation and funding the self-care kits and advocacy shirts. With that, I would like to thank the following for their support, guidance, and contribution to this study. As I end, let this be a reminder to take care of those who care. Thank you for your time.
Thank you. This is open for questions. I'm going to take the liberty of the first question again. I really appreciated your topic of mental health. It's such an important topic. And I'm just curious, what motivated you to do this investigation and work on mental health?
Yeah, as a healthcare worker myself, wellness is one of our core goals. So, as by definition, wellness is not merely the absence of the disease, but it is a holistic approach on the physical, mental, and social well-being of a person. So, when COVID-19 was very new to us, we were more focused on the effects of COVID on the physical aspect, the symptoms, its severity or its fatality. But I think it's equally important to see that how COVID affects us socially and mentally. And also in the Philippines, there are less data on mental health issues among healthcare workers. So I think as an epidemiologist, we need those data for action.
Thank you. I'm going to start on the right this time.
Thank you. James Gibson, I'm a former resident advisor in Tanzania. Here's my question. Many of the factors that you described as causing stress seem very familiar for healthcare workers here in the United States also. One thing that I missed or didn't see was problems with the perception of an adequate number of staff to care for the patients in the healthcare setting, especially, of course, in the last 3 years. Was that a problem, or were settings pretty well staffed, even during the coronavirus pandemic?
Yeah, thank you for that question. One of the factors that we noticed with high mean scores was the lack of manpower and lack of resources and equipment. So I guess it's also part of the factors where the health workers felt overload with their work, so they were so exhausted. So those were the factors that really, job stress factors that affected them.
Okay.
Yes.
Thank you.
Thank you.
Seymour?
Seymour Williams, Field Epidemiology Training Program Team Lead and former resident advisor in South Africa. Good work and important issue. Did you break out the data by those who had COVID and those who had maybe even received the vaccine? Were they more likely to be depressed, or they saw something as an action they could take? Did you break out the data that way?
Yes, I did. So for the previous COVID infection, the only statistically significant data that we have is that COVID infection, depression had higher odds among those who had COVID infection, 3 times more likely than those who did not have COVID. And for the COVID vaccination, I did try to check that, but it was not statistically significant.
On the right.
I'm reminded of David Snidak, formerly FETP resident advisor, Peru. I'm reminded of Bill Foege's reference to, I believe it was Will Durant, that said, science is common sense. And it seems common sense that all the stress factors and everything that was going on during this terrible period of the COVID pandemic, it's certainly understandable to have these types of problems among health workers. But I was curious, do we have any baseline assessment? I mean, healthcare in general is a pretty stressful occupation. So I was wondering, what the incremental change was during this period relative to pre-COVID times, number one. Number two, 8% awareness of the availability of mental health services that's quite striking. I was wondering if there was any post survey done to determine if that had helped, to what extent that the interventions were effective in increasing awareness and utilization of those health services. Thank you.
Thank you. So for the baseline data, actually the problem was there were lack of data of mental health status among healthcare workers in the Philippines. But yes, you're right that health workers are more prone to burnout even pre-COVID. So that for me is important, that I have made a data in the Philippines that can be a baseline data for the hospital also. And for that 8% awareness is actually part of the recommendation to do a follow-up study on the effectiveness of the recommended activities such as those psychotherapy and support groups and other resiliency programs. So not yet, but moving forward, we are going to look at it.
Thank you.
Thank you.
Over the left.
Thank you. So Jose Montes from the Mexican Field Epidemiology Training Program. Well, thank you for bringing mental health to the conversation. I think that's very important, and congratulations for actually translating your findings into actions. That is very important. So my question is actually regarding your model. I was wondering how, which was your, let's say your comparison. So you described there that doctors were at high risk of depression, but I don't know, what was your reference? Was it like other health personnel or other specific like professions, let's say nurses or other health professionals? Thank you.
Thank you. If you can go to slide 9, please. So in order to compare these two groups, originally the DAS-21 has 5 severity levels, but for the research, I tried to modify it into 2. So those who have normal scores were considered as normal or not having depression, not having anxiety, not having stress. And those who scored mild, moderate, severe, and extremely severe were considered with findings. So from those two groups, I was able to compare these findings with the social demographic, health profile, and COVID-19 exposures.
We'll do one final question over here on the right.
Yeah, my name is Dmitry Prabilsky. I'm with Division of Global Health Protection. And yeah, congratulations on a really important presentation. You know, my question was in relation to whether you had any data on actually those who were able to access services too, like if there was intent to access or awareness, but also just about their ability to access services and also the satisfaction with the services that they were provided. And then kind of a similar question was more the plan for repeated surveys, also looking at different cadres of health workers and where you may see mental health issues particularly concentrated too. Thanks.
Thank you. For the access to mental health services, actually it's free in the hospital. It has been available, but the awareness is really low that they can access this, or probably in other studies it says that even if the services were available, it's probably the stigma that held them back to do the consultation. But during the survey, I wasn't able to probe on the barriers because there's a lot. For example, the 36 health workers who had depression, 89% of them are willing to consult a psychiatrist or a psychologist, but actually only 14% of them had actually gone or sought professional help. But I wasn't able to probe on that, on why haven't they actually gone to a doctor. And for the satisfaction, for the satisfaction that will be moving forward study, and for the cadre, we have, or in the study you can see that the doctors were at higher risk of depression and stress.
Thank you.
Thank you.
Our final presenter, the last presenter for today, is Mr. Amadou Diallo. He's from Gambia and graduated from the Gambia Field Epidemiology Training Program, and is going to present what was the cause of epidemic acute kidney injury among children under 8 years old, the Gambia, July, November 2022.
Good evening. On July 26, 2022, the Ministry of Health was notified of an unusual increase in the number of children diagnosed with acute kidney injury. There were already 9 cases and 6 deaths recorded within 1 week. The nephrologist at the Gambia's only health teaching hospital was concerned because she suspected it might have been caused by contamination from paracetamol, recalling a similar incident in Nigeria linked to paracetamol brand called Mypikin. The Gambia FETP immediately sought to identify the cause or causes, determine the mode of transmission and the source. To identify acute kidney injury in children can be caused by a variety of factors, which include sepsis from infections, hemolytic uremic syndrome from toxigenic E. coli, shock from dehydration, cardiac surgery, and a child with pre-existing kidney disease are all common causes. Furthermore, ingestion of toxic substances such as cleaning agents, insecticides, or heavy metals, and contrast agents used in medical imaging are other causes. The most common cause of epidemic acute kidney injury is toxic drug ingestion. To commence our outbreak investigation, we hypothesized that the epidemic acute kidney injury could be due to infection from water sources because there was flooding in urban areas, and most of the cases were from these same health regions. And secondly, we considered the contamination in syrup medication consumed by already ill children. To identify our cases, we developed an outbreak investigation case definition and reviewed inpatient, outpatient, mortality registers at all pediatric departments of all hospitals and major health centers around the country. We interviewed patients, caregivers, and parents. We collected blood, urine, and stool samples to confirm and treat the cases. To further investigate the hypothesis, we collected water samples from water sources at patients' homes and community water sources to test for impurities and coliforms. And we also collected samples of syrup medications consumed by patients and some unconsumed syrups, patients from drugs sellers to test for toxins, and we analyzed our results descriptively. The case definition for the outbreak consisted of community, suspected, probable, and confirmed case definitions. The IEC material on the slide was used to identify a case in the community. We defined a suspected case in 3 ways. Only one is shown on the slide. A case can be confirmed when a suspected case with acute onset of oliguria, anuria, more than 24 hours, and of an unknown etiology, or a suspected case whose serum creatinine level was above the normal range after June 21st, 2022 in the Gambia. Our results. We line listed 129 suspected cases between June 21st and December 31st, 2022. And of these, 64% were confirmed for epidemic acute kidney injury based on our case definition. The median age of these confirmed cases was 17 months, with an interquartile range of 10 to 23 months. The median hospital stay before death or recovery was 3 days, with a range of 1 to 5 days. 85% and 95% respectively had vomiting and fever, while 30% had ingested promethazine as an initial treatment before going to the hospital, and 55% consumed any other syrups before hospital admission. Promethazine is an antiemetic medication available over the counter, and the other syrups are analgesic, antitussive, and antiemetic combination medications. The attack rate was 12 per 100,000 population among the under 10 years old. The case fatality rate was 87%. 76% of the children were from urban areas of the Gambia in Western 1 and 2 health regions. This map this is the map of the Gambia, a country in West Africa, which displays geospatial home location of these confirmed cases. The Gambia is surrounded by Senegal and the Atlantic Ocean. The country is divided into 7 health regions. The red dots show the geospatial home location of those who died, while the green dots represent the home location of children who recovered during the outbreak. The circle on the far left of the map shows where most of these cases and deaths lived. We could only collect and test stool samples from 4 cases, and all of them yielded Escherichia phagosoni, which is not known to cause outbreaks in humans. Also, all the water samples collected had fecal coliform isolated at the water laboratory, which also could not be responsible for the epidemic acute kidney injury outbreak. Our second hypothesis was toxins in medications, and since there is no toxicology laboratory in the country, we purposefully collected 23 sealed medication samples of the same batches consumed by the first few cases and sent them to WHO-approved laboratory in Switzerland. Quantitative nuclear magnetic resonance spectroscopy test was conducted, and the results revealed that 4 syrup medications manufactured by the same manufacturer on the same day and were imported into the Gambia in June 2022 contained between 0.3 to 21 grams of ethylene glycol and diethylene glycol per 100 ml syrup. This is above maximum acceptable limit of 0.1 grams per 100 ml ethylene glycol and diethylene glycol in syrups. 28% of the cases consumed these contaminated medications. When the Ministry of Health received the results of the contaminated medications, all promethazine, analgesic combinations, and cough syrup medications were quarantined from the importers, and a drug recall exercise was conducted in every home in the Gambia. Further syrup imports were restricted, and the Medicines Control Agency confiscated all syrup medications produced by the manufacturer in the Gambia. Some of the contaminated batches have not been recovered. Shortly after the recall exercise, cases reduced to 0. Until December in 2022, as shown in this epicove, when a private clinic issued the last bottle of contaminated medication in their clinic to a baby, which eventually died. As part of our public health actions to contain the outbreak, graduates worked together with information technology experts to introduce an e-surveillance system to track all AKI injury suspects in the country. In conclusion, the outbreak investigation was caused by ingestion of contaminated medication with ethylene glycol and diethylene glycol, which were manufactured the same day by the same manufacturer in another country. In a Jon Snow-like manner, when we removed the medications, the outbreak was brought under control. These are our references, and I thank you all. I would acknowledge you.
This presentation is open for question, but I want to have the first one. Taking into account the importance of, cross-border surveillance, knowing I know very well West Africa, then first of all, what you have done, and then, to prevent future outbreak like this, because we know the same manufacturer can be the same one distributing, medicine in the West Africa. And the first one is for Gambia. And the second one, what you have done with the other Ministry of Health of the West Africa region.
Now, prior to the outbreak of the acute kidney injury, within the Ministry of Health, we have been working with Senegal's Public Health Emergency Operations Center. So when the event happened, we contacted them and let them know what was happening in our country. We also shared information with the World Health Organization, who contacted the WHO office in Senegal, because this is the only country we shared border directly. So as a start, this is what we did, and then the first samples, in fact, that we collected, the blood samples were sent to Senegal. So our neighbors, they were aware of the situation. Thank you.
Okay, the second question on my right.
Okay, Doug Thurlman, EIS 1996. Thank you for a great presentation, and clearly there's a lot of evidence support the hypothesis that the medications were the cause. I'm curious that only 20% of the cases had indications that they had consumed one of those medications. So could you go into a little bit of why there was not a higher, usually when there's death, there's big causes like that, you'll have an overrepresentation of things that people think might have been causing it. So I'm curious, was it from lack of response or just time since the person had died, or what other explanations might there be for having such a low percent of people who reported that exposure?
I didn't get you clearly about it.
Well, so only 28, you said only 28% of people reported that the decedent or the child that was a case had consumed one of those medications, right?
Anyway, what we have done is, when we got the report that there is this acute kidney injury among children, and we thought it was the medicines, from there on, we were collecting all medicines from any patient that fits the standard case definitions, and then we started sending those medications for the test, for the toxicology test. And when we realized that there were contaminants in these medications, we advised all medications to stop, and that was it.
So maybe you didn't collect information from all the different cases, right? Okay. All right,
a lot of work has been done on that.
All right, thank you.
Rajesh Yadav, CDC India Country Office. Very nice presentations. My question is on the case definition. You have included in your suspect case definition your suspected exposure. Would that have limited you identifying more cases? Just curious. Thank you.
At the beginning, we were just opening our net wide to make sure we capture any of these, and then finally filter down at hospital level. That's all we were doing. Thank you.
Thank you.
John?
Hi, John Watson, EIS 2002. It sounds like, thank you for a very nice presentation. I enjoyed that. It sounds like work was done with Senegal cross-border to understand maybe the impacts or potential importation to Senegal. I'm wondering if you notified WHO, and since the medication was imported from an international supplier, I'm wondering, were other countries affected? Did it lead to recalls? Did your recognition lead to recalls in other countries as well?
A lot of work, yes, has been done, and we were closely working with the World Health Organization at country office, and they even sent some experts from Afro. We even worked with the US CDC, which sent a delegation there. So when we realized that there were contaminants in these medications, and this was announced globally, I understand Indonesia also had a similar problem, and then they were also struggling with the same challenge.
Interesting.
Thank you.
Thank you.
Chima?
Thank you. Well, just to ride on the back of the last question, you referred to the incidents the outbreak that occurred in Nigeria. And of course, Nigeria is a huge country in the West African region or sub-region. In course of your investigation and as actions to mitigate similar occurrence, did you relate to the Nigerian Ministry of Health? Was there some sort of collaboration in working together, maybe working through ECOWAS to strengthen the surveillance, as it were, and then maybe also look at the manufacturer. Maybe there's a relationship with what happened in Nigeria in the past.
Thank you very much for your question. We didn't work directly with Nigeria, but fortunately, we were working with Nigerians in the country. My resident advisor is a Nigerian, and this nephrologist is also a Nigerian, so it was very helpful. Maybe they have been contacting back home some experts to support us. They were very helpful in the investigation. Thank you.
Well, thank you. I didn't introduce myself because he called my name. My name is Chima Uwabunwa, EIS 2000, former resident advisor, Ghana, and former executive director, AFINIT.
Thank you, sir.
Thank you.
Reina?
Okay, I'm going to ask. Thank you so much. This is such a tragic situation that I wish did not happen as frequently as it does. I am drawn by the high mortality rate, particularly when you describe the deaths in that map where you've indicated where the children who died are. Is the high mortality rate a function of the population distribution along all of Guinea, or is that, pardon me, Gambia, or is it in relation to access to renal replacement therapy?
I think access is an issue here, because what we realize is all these kids that died of the acute kidney injury, most of them had to go out easily. Their parents or caregivers had to go and get medicines from the nearest either health facility or pharmacy. And these are more accessible in the urban areas than in the rural areas. That's what we observed. Thank you.
Thank you, Mr. Diallo. We can go to the seat. With this, the last presentation, and then we close the presentation for tonight. And then now we are going to proceed to the next step of the ceremony. And then I'm calling Carl Reddy and Kip Barrett to come on stage. Okay. Thank you. The next step is, and then we are going to give certificates to the oral presenters, to the 8 oral presenters. Yesterday we got Alice Wynn, who presented. If Alice is in the room, please come to receive your certificate. Miss Teresa Amutieni. Come and take your certificate. Miss Saya Gazezova, please. Mr. Amadou Diallo, please. Mr. Dauda Kamara. Miss Maria Kasmira Maramag. Mr. Moses Jiru. And the last one is Mr. Javier Novello. I think I did the good exercise and then to repeat the name all the evening, and then I think I spell them well. Thank you. Carl, for the next step.
Thank you very much, Solomon. Okay, so the first part of the awards is the photo contest. The FETP International Night Photo Contest is an annual tradition. The contest gives FETP trainees and graduates the opportunity to convey the impact of their work through compelling photographs taken in the field. A panel of judges from TEFINET and CDC review the submissions and select the first, second, and third place winners.
Hey, Carl, before Carl announces these winners, I'd like to invite a couple of others up onto stage to hand out the certificates. I'd like to invite our moderator from yesterday, Dr. Reina Tercios Ruiz, and then the FETP team lead here at CDC, Dr. Seymour Williams.
Thanks, Kip. Okay, so there's a drum roll in the background. You might not hear it, but wonderful, wonderful collaboration. Okay, the third place winner is Giang Phan from the Vietnam FETP. The second place winner is Ninael Jonas from the Tanzania FELTP. And the first place winner, drum roll again, please. Great. Is Shaban Senyange from the Uganda FETP. So Julie Harris is receiving the award on behalf of Shaban.
Okay, well, congratulations to the photo contest winners. Now we're going to move on to our next award, and that is the Jeffrey P. Copeland Award for Excellence in Poster Scientific Presentation. The Jeffrey P. Copeland Award for Excellence in Poster Scientific Presentation was established in 2014 in honor of Dr. Jeffrey P. Copeland, former director and 26-year veteran of the U.S. Centers for Disease Control and Prevention, for his outstanding contributions to improve public health globally and his commitment to excellence in scientific research, analysis, and presentation. The Jeffrey P. Copeland Award is presented to the winner of the scientific poster presentation that most effectively emphasizes the results of an investigation and its impact on public health. So, before I announce the winner of the poster contest for this year, I do want to say that I mentioned this in my opening remarks about how excellent the posters were last night. And true to the excellence across the board, it was a very, very tight competition for the Copeland Award this year. So before I announce the winner, I do want to mention two posters that were not the winners, but were very, very good and deserve honorable mention. We don't have a certificate for those presenters, but I did want to acknowledge the excellence of their work. The first of those is Camille Jacqueline from the UFEM program from Spain. So congratulations for a great job. And Janice Zong from the Canadian FETP, also very excellent work. But the winner of this year's Jeffrey P. Copeland Award for Excellent Poster Presentation is Zoe Baldwin from the Australian FETP. First incursion of Japanese encephalitis virus in New South Wales, Australia, 2022.
Okay, we now come to the William H. Fagey Award for Excellence in Oral Scientific Presentation. The William H. Fagey Award for Excellence in Oral Scientific Presentation was established in honor of Dr. William Fagey, the renowned epidemiologist, Presidential Medal of Freedom recipient, and former director of the U.S. Centers for Disease Control and Prevention, who is credited with devising the global strategy that led to the eradication of smallpox in the late 1970s. The award is the highest FETP International Night's honor presented for the best oral presentation. Oh. And the award goes to Saya Gazezova of the Central Asia FETP.
Congratulations. Your certificate is printing now. You can't do it so fast. But please
Okay, well, congratulations to our presenters. I now have the pleasure of presenting a very special award. This is our, I think our third year presenting this award, and this is the Sarah Lowther FETP Memorial Award. The Sarah Lowther FETP Memorial Award provides support to a fellow or recent graduate of a field epidemiology training program to conduct a project that makes significant contributions to infectious disease prevention and control in their country. The award honors the memory of Dr. Sarah Lowther, who made significant contributions to public health and passed away in May of 2020. Dr. Lowther led the Epidemiology Technical Support Unit for FETP at CDC, and she was passionate about FETP as a means to develop and mentor young field epidemiologists around the world and build global field epidemiology capacity. The Sarah Lowther FETP Memorial Award will be presented annually during the FETP International Nights. This year's Sarah Lowther Memorial Award has been awarded to Dr. Arunag Dungdial from India, the National CDC in India EIS. I don't think he is with us tonight, but we do have a certificate if somebody from the India EIS program would like to accept on his behalf.
Okay, so the last award for this evening is the CDC Director's Award for Excellence in Epidemiology and Public Health Response. This award is presented in recognition of significant contributions towards successful responses to public health emergencies, natural and man-made disasters, as well as disease outbreaks. Nominees can include FETP or FELTP resident advisors who have provided leadership working as part of a response and have been successful in overcoming challenging circumstances. The award is also to recognize excellence in epidemiologic practice or research and contributions that address a public health issue of major importance by applying epidemiological principles and methods. Nominations can recognize accomplishments that improved human health, made a substantial reduction in burden of disease, or represented innovations to public health practice based on epidemiological foundations or implementation of epidemiologic approaches. Recognized contributions should be practical, explicit, and applied rather than theoretical or implicit. This is a duet.
Yes, and so I'm very excited to present this year's CDC Director's Award for Excellence in Epidemiology and Public Health Response to the Ukraine Interventional Epidemiological Service. And just to say a word of congratulations to the Ukraine's program. This year, there were more nominations for this award than I can remember in my time here. I believe more nominations than ever, and some very, very strong recommendations. So this is quite an honor to have won this award this year. And I think you can imagine the challenges through which the Ukraine program has persevered over the last couple of years. through not only through an ongoing pandemic, but 16 months of open warfare in Ukraine. And through all this, they not only continued their advanced FETP program, but launched 2 other tiers, and were participating in 3 tiers of FETP during this time. And as if running the program and successfully training graduates, FETP fellows, weren't enough through these challenges, the Ukraine Public Health Center, which hosts the program, also positioned the FETP in Ukraine to conduct many successful and impactful public health investigations with important impact and consequence, including outbreaks like anthrax, tularemia, foodborne outbreaks, and responding to the humanitarian crisis. So let's all congratulate the Ukraine Interventional Public Health Epidemiologic Service again. Thank you. I believe we have a representative from the CDC, the regional program at CDC, if Dr. Tushar Singh is willing to come accept the certificate. I don't think we have a representative from Ukraine here tonight. I'm just going to do closing remarks and then we're having a Okay. Well, it's just a little bit past 9 o'clock, so we have not done too bad with time. That concludes our awards ceremony. I just want to take a minute to start by thanking all of you in the audience. It's great to have such a support. Many of you, maybe most of you, have been at the EIS conference all day today. I know this makes for a very, very long day, and it's quite a testament to the quality of the FETP presentations that you're willing to stay and spend your time here this evening. It's been quite a pleasure, and just really a great event. I want to thank those who are joining us from online. I hope we have many people that are joining us in the live stream tonight in Atlanta and at different times around the world. Thank you for joining us. We really appreciate it. And then I have a few more thank yous for making this event special today and yesterday. Let me start by thanking TEFINET again and the Task Force for Global Health for their amazing collaboration with us at CDC to not only to pull off this event tonight and last night, but also generally for the longstanding collaboration to support FETP and making it what it is today. So thank you very much. And thank you for the prompt here, because that was actually my next point. Is I wanted to thank the planning committee who have been working extremely hard over the past several months. Many members of this committee are new to the committee. For many years, we had just this stalwart group of people who really knew International Night in and out and knew how to make it run. But we've had some turnover, and we've got some new folks on the committee who have just done an excellent job, and I feel like we've really brought it home tonight. So thanks very much to this committee for all of your hard work. And thank you to the EIS program. Seymour gave them a shout out last night, and I think we just don't want to forget the importance of the EIS conference, and it's so great to have this event back jointly with the EIS conference in person this year. So thank you so much to Dr. Eric Pevsner and his team for his great support of FETP and allowing us to be a big part of the EIS conference. Thank you to the judges and the moderators who've pulled extra duty, both for the posters and the oral presentations. They really did an excellent job, kept us on time, and kept things moving and kept things interesting. So thank you very, very much. And then before closing, I just want to turn my attention back to those on the front row tonight and those that were on the front row last night, those that did excellent presentations and spent an incredible amount of time preparing their presentations, but more importantly, gave their heart and soul into those investigations and that important public health work that led to important public health impact that you heard about tonight. And behind each of those fellows, residents, presenters, is at least one mentor, maybe more mentor, and then there's a whole program behind them, program staff, and we just cannot forget those people that make things run. So congratulations to all of you, and congratulations and thanks to your mentors and your programs behind you. And I wish everyone a wonderful evening, and thank you for being here. And before the presenters scatter, I would like to ask them to come to the stage for a group photo, the oral presenters. Thank you.